This is the most common problem that you can have in your knee.
Ooh.
This is it. Odds are this is what's wrong with your knee. Yeah, it might be something else, but most likely it's what we're about to talk about. I'm Dr. Paul Zalzo.
I'm Dr. Brad Weening. Welcome to Talking with Docs. We have a guest today, Dr. Tim Deacon, a knee specialist orthopedic surgeon. Welcome.
Thanks.
He is like the knights who say knee from Monty Python.
Okay.
His whole life is the knee.
So what are we talking about? What is the most common knee problem that you see in your office as a knee surgeon?
Well, the most common complaint is pain in the front of the knee, and it's usually coming from the kneecap joint.
Okay.
There's two main causes. The first one would be instability, and I think we're going to do another video on instability. But even just kneecap source pain, so from what we call your patellofemoral joint, or where the kneecap sits in the groove in the thigh bone, pain coming from that joint is the most common complaint that I see in a knee practice.
Did you think that would be it? Did you think your kneecap could be causing you this much problem? The kneecap, what was the first hockey puck many years ago, right?
What?
Yeah, that's what that cow and kneecap was the first hockey puck.
Oh my.
Tell
Who are you?
Google that.
Okay,
Google that.
So let's start at the beginning. So who's showing up at your office and why do they have this? So what do the patients look like? Age,
Okay,
gender?
So the most common age group would be adolescents.
Okay.
And it's more common in females than it is in males.
Okay.
The complaint is always pain in the front of the knee. And you know, a lot of parents sort of write it off to growing pains.
Sure.
But I have a lot of these adolescents come into my office. The pain usually develops in their early teens and gets worse over that time frame. We think there are a number of causes. Some of them are just the architecture of that individual's knee. Some of them are the fact that the bones are growing very quickly, and so they're probably outpacing the muscles. So the muscles
So
aren't
then it
keeping
is a little
up.
bit growing pains for those parents that are saying,
Okay.
right?
Wait,
Yeah, a little bit.
Yeah, a little bit.
Okay.
Usually pain sitting, especially in tight conditions like in a movie theater or in a plane. Going upstairs is a pretty classic cause of the pain. Some people will say they feel clicking, cracking, grinding in their knees. And so I'll do an examination, and a lot of these people have a little tendency for the kneecap to deviate out to the side as they straighten their knees. And so the kneecap, we say, isn't tracking perfectly. And the reason for that is probably that their inside muscle, what we call the VMO, or the vastus medialis obliquus, is a little underdeveloped. That muscle hasn't quite kept up with bone growth. So that's by far the most common complaint that I see in my office.
Okay, and would you say there are a few of those people who have had a traumatic event, maybe fallen onto a bent knee or had a dashboard injury or something, but most of them don't have any specific trauma. It's just life.
Exactly.
They're like, what the heck? I didn't even do anything.
Exactly. That's a very good point, Brad, because some of these are due to some kind of trauma or overuse.
Right.
It used to be that this was a really common complaint in Army cadets.
Oh.
So there's adolescents that normally maybe weren't as physically active and are being asked to march, particularly carrying things and in boots, and they develop anterior knee pain. So that was one of the most common areas that we were able to look at this problem was in Army cadets.
And I also see it too in people older than their adolescents, but they all of a sudden started jogging or all of a sudden started a new sport, and oh boy, the front of my knee is killing.
Right.
And
So it can be due to an injury, maybe an impact to the front of the knee, overuse,
Yeah.
or underdevelopment of the muscles.
so
right?
new activity that you take on that's going to declare that underdeveloped muscle.
Correct.
And we call this anterior knee pain. We also call it patellofemoral syndrome.
Patellofemoral syndrome.
And you'll also hear it called chondromalacia patella, which isn't exactly what it is, but it could be one of the causes of this anterior knee pain. It's just softening of that cartilage underneath the kneecap.
So sometimes you get softening of the cartilage, in some cases because the kneecap's not tracking properly and there's point pressure in the cartilage, and that cartilage responds by breaking down and getting a little bit rough. So cartilage should be perfectly smooth, and this cartilage sort of looks a bit like crab meat. And so that's what causes that chondromalacia. That's chondromalacia, that breaking down of the cartilage. And it can cause clicking, cracking, grinding.
So that's it. You might hear anterior knee pain, you might hear patellofemoral syndrome, you might hear chondromalacia patella. Essentially all kind of the same thing.
Right. And this condition can continue on through life. So a lot of people will say, oh, my knee makes a lot of noise, particularly going up or down stairs. And that is the long-term effect of that kneecap problem. So what do you do with it?
Well, let's go back a little bit. So they come to your office. to give you the story. So when you examine them, you say, there's not a ton to find. You mean you have
Right.
some areas of tenderness during the examination, but the knee itself looks like a normal knee, might be a little bit swollen, typically has a full range and is stable. Do you do any special tests other than your examination and your history, even though we know that that's most of the answer already?
Right. So you're going to get X-rays for sure.
Okay.
Do you ever do the quadricep grind test that was described
Yes.
years ago? You still do that one?
yeah.
That's where you apply some
It's
pressure
really
just above the
painful.
kneecap and then ask the person to contract their quads, right? And
yeah.
if they reproduces their pain, that it tells you that you're having pain.
I do that test if people don't like it. You
I
get one
see.
crack at that.
So they used to call it Clark's test, and it's a patellar compression test, and ask the person to contract their muscle.
Yeah.
I think it's cruel and unusual punishment.
Yeah.
Yeah, but if you're really wondering about the diagnosis, if you're not sure, then that's a test that was done traditionally to see
Yes.
if that's where the pain is coming from.
So you said standing x-rays. And for me, a lot of times the x-ray that I don't get when these people are in my office, I see a front view or what's called an AP view. I see a lateral view or view from the side, but I don't see the one that I care about the most, or the skyline view, which is that view that gives us your knee is bent, and it's a picture shooting straight at you, but I can see how the kneecap is tracking in the groove of your femur called your trochlea.
Yeah. So a kneecap view.
Yeah.
Later in life, that is really important for determining whether or not there's some kneecap arthritis too.
Right.
That's a
They're
thing,
not
right?
directly related too, right?
Right.
The two are not directly related, but some people will go on to develop kneecap arthritis, and that will be their biggest problem down the road.
Yeah. So most commonly, this is an anterior knee pain or patellofemoral syndrome, but there is an overlap in symptoms with someone who has patellofemoral arthritis. They could feel a lot of those same symptoms: pain
Right.
with your knee bent for a long period of time, going up and down stairs.
So do you need an MRI? I guess the big question.
Yes.
And you probably don't.
We don't.
But if the pain is persistent and is not responsive to physiotherapy, which is focusing on that vastus medialis obliquus muscle, down the road you would get an MRI.
Okay, so you might get an
Anything
MRI, but
else.
now you already teased us with the treatment. So
Hey, that VMO, yeah. Since you're talking about the treatment in
Yeah.
terms of physiotherapy and strengthening, what is that exercise that strengthens VMO the most?
So, and it's a hard muscle to try and just get to fire on its own, but the VMO works more out into full extension. So the exercises are trying to do straight leg raises and knee extensions near full extension. That's the key, right? And you can also work the glutes or the core muscles, work the abductors and adductors in the thigh, which are muscles that will help the VMO to fire. But working the quads out near full extension is the key.
Right. So if you have this, or you think you have this, a simple treatment that you can do yourself is just leg extensions, and it's just the last 15 degrees or so of knee
Right,
extension.
exactly.
So legs out straight, bend it 15 degrees, straighten it again, bend it 15 degrees. So that's what you're doing with your knee. You can put a little weight on your ankle, a light weight in the end to help increase resistance. So you can build up your VMO muscle that should help your patellofemoral syndrome.
And you do it with your foot pointing straight up, and then also with your foot pointing out. Don't point your foot in, because that doesn't work the muscle.
okay, so you've done some physiotherapy. What about for pain? Is there anything I can take?
Yeah, I mean, I just tell people to take an anti-inflammatory,
Okay.
and you can use it either by taking by mouth or even better, rubbing it on the surface.
Topical.
Topical anti-inflammatories are great.
Okay.
I'm a big
And
fan
they're
of
safe.
those.
They're safe. They're much safer than taking by mouth.
Any role for injections?
That's a very good question, because there is an increasing evidence that injecting something like platelet-rich plasma or hyaluronic acid into the knee is helpful for patellofemoral source pain. And in fact, there's some studies that showing adding a little bit of corticosteroid to those two may make the effect even better. And so these are the people that don't respond to physiotherapy. You're looking for the next step. What am I going to do to help these people? And there's a thought that maybe injection therapy is the next step.
And do you know any good injection videos someone can watch? How about ours?
We have a really good injection video with Dr. Tika that talks about all the different things that we can inject in your knee, the evidence for them, what's worth considering and what's not worth considering. So you've done an injection. Someone comes to me and they say, listen, doc, they pull something out of their little bag off to the side. They say, I got this brace. Any role for wearing a brace of any sort?
Well, braces can make the problem worse in as many cases as they make it better.
Right.
And so I tell people, try it and see if it helps your knee pain.
Totally.
There's no harm if it helps your knee pain. Just make sure it's not too tight and cutting off the circulation. That's the
Right,
key.
and that can be something as simple as a neoprene sleeve that has a little cutout, or something that has some side-to-side support with little bars. Or again, ultimately it has to be comfortable, and you have to, when you wear it, feel like it's making a difference. Otherwise, there's no point.
Right.
Okay.
Activity modification is another thing. If you're doing a certain activity that exacerbates this problem, don't do that activity. It's the classic, hey doc, it hurts when I push here. Don't push there.
Absolutely.
God,
That
it
is
hurts when
another
I
reason.
do this. Don't do that, right? Try on your long flight, don't sit with your knee bent for the whole time. Get up and walk around. In the movies, sit on the aisle, stick your leg out. You might trip someone, but your knee will feel better.
So, in the final thing, is there any place for surgery?
Right. So I
And,
come to your office. I say, 10 years I've been suffering with this. I
Right.
cannot live with my knee. You have to do something.
So the way I approach this, and this is 45 years of experience doing this, is that sometimes a knee arthroscopy and smoothing out the back surface of the kneecap will be helpful for the pain. What I look for is I look for lower pitched cracking, popping, more baritone as opposed to fine pitch. The fine pitch stuff I can't really make better, but the lower pitch means that there's maybe flaps, there's maybe cracks in the cartilage, and in smoothing it out, I might make the person's kneecap pain better. But the problem is, I'm taking cartilage away.
Sorry, so just to be clear, you're telling me that the pitch of the sound from their knee helps determine your treatment?
Yeah, absolutely.
That's amazing.
Are you like auscultating with a stethoscope?
Well, it's more a hands-on thing. And the more the kneecap pops, the more physical abnormalities there are on the back surface of the kneecap, the more I can help.
More
with
like a mechanical
arthroscopy.
type problem.
Exactly.
Okay.
Exactly.
Well, I find myself often telling people when their primary complaint is sounds from their knee, we don't worry about it if you're not having any pain or any symptoms.
Sure.
The sounds, don't worry about, but if you're having pain associated with it, that's when we worry about it.
I tell people that just limits your potential for a career in espionage if you have really noisy knees.
Yeah. Or an opera singer with your mic'd up, that can
There you
throw
go.
it off too.
Okay, so surgery is an option, but unfortunately, what I would say from my experience, a lot of these people do have, like, we can improve the symptoms, but they do suffer from this, and it's going to be something that likely persists. It's not curable per se, and it's a little frustrating for people, as for surgeons and for the patients themselves. It's a hard problem.
It's a frustrating problem. It can be a lifelong problem, and doing the exercises is a never-ending story. I mean, you have to keep up the exercises for sure.
I think a notable mention that we didn't talk about it, I think weight loss is worth considering. I think weight loss is very difficult to do. Losing weight is not going to make your knee normal, but often it can improve the symptoms. I use the analogy of if you have a knapsack that has 40 pounds of butter in it, and you never get to take that off, that's going to be sore. If you take that knapsack off, it's going to feel better. It doesn't make your knee normal, but it is going to help. So if you can find a successful strategy for losing some weight, it's always worth
And it
considering.
doesn't have to be butter. That 40 pounds, that could be kale. Even 40 pounds
Do
of
you
kale.
know how big your bag would have to be to have 40 pounds of kale?
I'm just saying it's going to hurt.
It would probably feel better, actually, if you had
40 pounds of kale on your back will not help
Yeah.
with patellofemoral syndrome. 40
Okay.
pounds of chicken wings will make things go by a little easier.
Now that is a great summary. This is a common problem. You are not alone. Please leave a comment. If you have anterior knee pain, something that you've done that's been successful, share it with other people. If you like this video, please like it,
I have
subscribe
one
to our
more
channel.
question.
Oh,
And when you were at the beginning of your practice, was patelectomy still a thing yet, or
Ooh.
had that already gone by the time you got into the picture?
No, that's still an option. It's the absolute end
So
stage.
patelectomy, where you remove your kneecap.
Yes, absolute.
Is that still done
stage.
today, would you
It's
say?
still done. There are still people who have such severe pain that can't cope that we take their kneecaps out, and it's very rare. I do it maybe once every 5 years.
Really?
wow.
Yeah.
I've never done one of those for knee pain, but I have seen people who've had their
Yeah,
patella
same.
removed and used as hockey pucks.
Now you know. So if you like this video, please like and subscribe to our channel.
And remember, you are in charge of your own health.
Thanks, Dr. Deegan, for joining us this morning. We'll see you next time.